Hey guys, I hope you all are doing well. So now let's start the topic. Today's topic is thyroid supplements and suppressants. So mainly the thyroid gland is located in the middle of the neck and surrounds the trachea like a shield. So mainly the hypothalamus is responsible for stimulating the thyroid hormone and which activates the anterior lobe of pituitary. So there is a thyroid dysfunctions which is mainly hypothyroidism and hyperthyroidism. So hypothyroidism is due to the decrease of thyroid hormone in the body and which is mainly due to the decreased iodine in the diet. And the reason is maybe decreased functioning of the thyroid tissues, decreased TSH due to pituitary disease, decreased TRH related to tumor, disorder of the hypothalamus or thyroidectomy, absence of thyroid glands. So the gland mainly involved over here is pituitary and hypothalamus. So there may be a disorder of pituitary or disorder of hypothalamus. Now there may be a decreased iodine, there may be a dysfunction of or there may be a decreased functioning of thyroid tissues. Now, the another thyroid dysfunction is hyperthyroidism, which is due to the hyperactivity or hypersecretions. So, it mainly causes Graves' disease and hyperthyrotosis, hyperthyrotoxicosis. Mainly, it is due to the here what happens, there is an increased TSH due to the negative feedback. Mainly, the stimulant goes into the TSH and it will in return decrease or increase the TSH by negative or positive feedback. Now, the thyroid hormone. Mainly there is a three thyroid hormone, different hormones naming thyroxine, tetraiodothyronine, mainly known as levothyroxine or triiodothyronine, and calcitonin. Calcitonin is mainly responsible for calcium metabolism. Now let's move on to hypothyroid state. So mainly the first state is cretinism. Cretinism mainly occurs in infant and children in a form of sporadic cretinism and endemic cretinism. The mainly treatment is started when the thyroxine dose is about 8 to 12 macrogram per kg per day. Then the earliest possible treatment is to prevent the further deteriorations. Now this mainly prevent further deteriorations of physical and mental development. Now the another hypothyroid state is adult hypothyroidism, that is myxedema. Myxedema, this condition develops when there is a autoimmune thyroiditis, there is thyrotomy, and drugs such as iodides, lithium, amidodrone, and their deficiency may there will be a deficiency of iodine. Sometimes the deficiency of iodine is severe, so the treatment started with the L-thyroxine in a low dose, which is 50 macrogram per day, and increase every day by 2 to 3 weeks by maximum 100 to 200 macrogram per day. The dose is adjusted by the clinical response and the serum TSH level, which is the clinical response and the TSH given. Okay, so the treatment of subclinical hypothyroidism case is optional depending upon the clinical features of hypothyroidism with TSH. TSH plays a very important role as through the clinical manifestation and the adjusted clinical response, the doses are were given. Now, the another hypothyroid state is myxedema coma. It is an emergency condition due to the acute hypothyroidism and rapid hypothyroid hormone, and due to may sometimes due to the replacement therapy. So the treatment is L-thyroxine is administered IV and in the dose of 200 to 500 macrogram in the start and followed by the 100 macrogram IV once daily till the oral therapy. Now, T3 is not given because it causes fatal cardiac arrhythmias. Now, there is a steps for giving there is a general management of giving the T4. So first one is rewarming the patient with the help of blanket or direct heat. Then another one is corticosteroid, which is a naloxone. And next, the intravenous antibiotics are given if the evidence of infection is there. Now there is a collection of electrolytes for hyponatremia. Now correction of hypoglycemia, ventilation support may be required. Now cardiovascular support if required. Now the another form of hypothyroid state is non-toxic goiter. So first one is mainly it could be endemic due to the iodine deficiency or sporadic by due to the defect in the hormone synthesis. The patient present with enlarged thyroid gland are known as goiter. So clinically, the patient with euthyroid and hypothyroid. Mainly the euthyroid and hypothyroid. So the iodine deficiency need to be corrected, and with the help of iodinized salt and other measures. So the treatment is replacement therapy. Thyroxine therapy may be withdrawal after years, or in some cases, some may need long-term therapy. So this is it. Now the another term is goitrins. Mainly the goitrin causing agents are found in plants such as cabbage, turnip, mustard. So the consumption of these goitrins may contribute to the endemic goiter and certain iodine deficiency reasons. Now there is a goitrins may cause goiter in who feed on these plants. So benign thyroid nodules and TSH responsible thyroid carcinoma. So these thyroid enlargement may regress with the TSH is suppressed by T4 therapy. Now miscellaneous uses. There may be a infertility, there menstruational disorders, refractive anemias, and hypothyroidism may not cause of this disorder. So let's move to the most important part of this topic, that is the synthesis of thyroid hormone. So I'm going through a very short way to make you understand. I'm not giving you a long speech, so let's look after that. Now first one is there is a structure over here which is a thyroid follicular cell. There's endothelium, there's a blood, there's a colloid. Okay, so what happens, the iodine trapping or iodine intake, mainly the formation of thyroid hormone, works on the two principles, that is the thyroglobulin and iodide. So mainly the glycoprotein thyroglobulin is synthesized from the rough endoplasmic reticulum, then it is secreted into the colloids. Now the second one is iodide. So iodide is actively pumped into the cell by sodium iodide symporter, that is this one is I and sodium and iodide symporter, which is then passively transported to the colloids along with the thyroglobulin. So T4 and T3 are involved in the various bodily functions, and calcitonin is primarily involved in the regulation of calcium metabolism. Now there is a certain steps. First one is iodine trapping and iodine intake. So I have already explained you there is a two, that is glycoprotein thyroglobulin and iodide. It is mainly synthesized in rough endoplasmic reticulum of the cells, and iodide is actively pumped into the cell by sodium iodide symporter. Now what happens over here, there is a when it comes to the colloid, there is a iodination, the process known as iodination happens. So in the process of iodination, there is a iodide ion taken up by the follicular cell by the active transport mechanism, with the help of sodium iodide transporter. Now this iodide ion are oxidized to iodinium. Now iodinium ion by the membrane bond, which is known as thyroid peroxidase. Here you'll better understand all these things. So After coming to the colloid, it the thyroid peroxidase act on the iodide, and it converts it into a iodinium ion, that is I naught. Okay, I've denoted it by the I naught. Then the next step, the hormone synthesizes begin with the addition of iodine to the tyrosine residue on the thyroglobulin molecule in the process. So what happens, this iodide is mainly combined with the comes in contact or stick together with the tyrosine residue on the thyroglobulin molecule, and this stick together is known as iodination, and it will produce thyroid hormones, that is monoiodothyronine and diiodothyronine. Okay, so the reaction does not require any enzymatic interventions. So let's move further. The next step is coupling. In coupling, the final step is the synthesis of thyroid hormone. So it is oxidative reaction for the thyroid peroxidase enzyme, that is TPO, and the adjacent thyroresidue pair together. So this I naught plus tyrosine residue receptors are paired together and makes the entire complex and re-enter into the follicular cell. Now this proteolytic enzyme present in the thyroglobulin will digest the thyroglobulin that liberates free thyroid molecule, that is the formation occur over here is that diiodothyronine. The pair of diiodothyronine will make up T4, and the one diiodothyronine and monoiodothyronine will make up T3. Now let's see again the diagram to understand all these concepts. Now what happened, this thioglobulin enters the colloids, and this iodine also enters the colloids by a sodium iodine transporter symport. Sorry. Now the iodination happens where iodine is converted into iodide by the thyroid peroxidase. Okay, now this iodination will goes into the coupling, that is conjugation, where the adjacent thyroid residues bind together or pair together to re-enter into the follicular cells. Now this complex will break down, and the proteolytic enzyme digest the thyroglobulin, and thus releasing the free thyroid molecule, that is the T3 and T4. Now this T3 and T4 will goes into the circulation, and they makes also a process which will be explained later. So after releasing T3 and T4, it is released into the circulation, where they quickly bind to the carrier protein for transport to targeted cells. The free extracellular T3 and T4 enters the targeted cell through the transporter protein, and once they are inside, the amount of T3, which is the greater biological activity than the T4, is regulated by deiodinase enzyme, that is D1 and D2, that catalyzes the conversion of T4 to T3. Now thereby increasing the intracellular level of D-active enzyme, that is D-active hormone, where D3 serves to inactivate D4 by converting it into a D reserve, we call reserve T3. Now this T3 moves to the nucleus and binds to the thyroid hormone and thyroid hormone receptor, which then forms the heterodimer with the retinoid X receptor, which induces the transcription of target gene known as thyroid receptor element. So and this will lead to the synthesis of various regulatory protein that will mitigate various psychological responses. Okay, now there is a huge process, that is the T4 enters and T3 enters, where the T4 is converted into T3, and T4 is again serves into inactivate T4, so by converting enzyme into reservoir T3. Now there is a various drugs we have to study for hypothyroidism, which is also known as anti-thyroid drugs. So there are by inhibiting the processes happening over here by the in the process of synthesis of thyroid hormone, we can inhibit the synthesis of thyroid hormone. So by inhibiting certain steps, we can easily inhibit these processes. So thyroid hormone synthesis inhibitor mainly inhibit peroxidase, which is the first step, which is the second step, I'm sorry. Now it will also inhibit iodination. Now it will inhibit coupling. So the first group of drug belongs to inhibition of thyroid hormone synthesis is uracil, propyl thiouracil. Now, this will inhibit peripheral conversion of T4 to T3. Now, the pharmacokinetics of this drug is mainly it is taken orally and metabolized in liver, excretion through kidney, and it has high plasma protein bond, and it is mainly safer for pregnancies. Now, propyl thiouracil is given in a dose of 50 to 150 mg thrice daily in the starting, and it is followed by the 55 to 15 mg OD/BD for maintenance therapy. Now, the another group of drug is methimazole, and it is a given in a dose of 5 to 10 mg thrice daily in the starting, and followed up by the 5 to 15 mg once or twice for the maintenance therapy. Now, the adverse effect of methimazole is fetal hypothyroidism and bone abnormalities. Now, the another group of drug belongs to the thyroid hormone synthesis inhibitor or antithyroid is carbimazole, and carbimazole is converted into methimazole by the absorption of carbimazole, and have a longer T half. So let's move further. It is given in a dose of 5 to 18 mg thrice daily in the starting, and 2.5 to 100 mg once or twice daily for the maintenance therapy. Now, the therapeutic uses of this thyroid synthesis inhibitors is mainly thyroid hypothyroid state or thyrotoxicosis in both Graves' disease and toxic nodular goiter, and thyroid strom has a main effect on these drugs. Now, another uses is hypothyroidism in pregnancies, because in pregnancies radioactive iodides and thyroidectomy are contraindicated. Now, along with the radioactive iodide and propranolol to improve the recovery. So, by combining these drugs, we can improve the recovery in thyrotoxicosis, and preoperatively before the surgery may used. Now, the adverse effect of these drugs may be there may be a reversible hypothyroidism or goiter may be occur due to the over treatment only. Now, there may be some drugs some effects on the GI disturbance like nausea, vomiting. There may be a mild rashes, itching, joint pain, graying of hair, loss of taste, pyrexia, which is the increase of body temperature. Now, we can also inhibit hypothyroidism, that is anti-thyroid hormones or that drugs inhibiting iodide trapping or ionic that is ionic inhibitor. So these drugs mainly inhibit the synthesis of thyroid hormone and also inhibiting the iodide trapping. The main effect of these drugs is they will increase the toxicity, and or mainly highly toxic in nature, and they are not used clinically. So the drugs belongs to this is thiocyanate, perchlorates, and nitrates. Now, another form of group of drug is hormone release inhibitors. So what happened over here, that is iodides is has a have a paradoxical effect in the thyroid hormone synthesis when it is given in a therapeutic dose. Now, the symptoms the mainly it high concentration inhibit almost all steps of synthesis of thyroid hormone. So, pharmacology of hormone release inhibitor is first of all the symptom of thyrotoxicosis subside within the 2 to 3 days, and the gland starts sinking within 2 weeks period, and it is given orally, and it is given orally in a form of solutions. So the dose of 100 to 300 mg per day therapeutically, that is therapeutically, is healing of disease. Now it is also given in 5 to 100 5 to 10 mg daily profile actively in intended of prevent disease. Now, the therapeutic uses of these drugs are they are mainly used in thyroid storms, prophylaxis of endemic goiter. It is generally used as a iodinized salt. Now, this is perioperative preparation of the thyroidectomy in Graves' disease. It is mainly used in antiseptic and mucolytic agents in a form of tincture, iodide, and potassium iodide in cough syrups preparations. Now, the adverse effect mainly include acute effects and chronic effect. Now, the acute effect mainly consider hypersensitivity to iodide, fever, arthralgia, that is pain in joint, swelling of lips and eyelids, angioedema of larynx, that is swelling of deeper layers. Now, bacterial hemorrhage, that is tiny round brown purple spot due to the bleeding in the skin. Now, the chronic effect includes due to the overdose, there may be iodism, that is a headache, rhinorrhea, then sneezing, lacrimations, swelling of eyelids, inflammation all mucous membrane, that is hypothyroidism, goiter. Now, the another form of group is thyroid tissue destroying agents, and I 131 is only radioactive isotope which has therapeutic importance. So after the oral administration, it gets concentrated in the thyroid follicles and emit beta particles. These beta particles will penetrate about 0.5 to 2.0 macro curie, that is of thyroid tissue and albeit it. Now this hypothyroid state is corrected. Now, the pharmacokinetics include physical half-life, and radioactive isotope is mainly given in a dose of 25 to 100 curie for diagnostic purpose, and 3 to 6 curie in a therapeutic doses. Now, the mainly the response starts after 3 weeks, and it reaches at the peak after 3 months time. Now, the advantages of this group of drug is there is no risk of surgical scar. There is no injury to the parathyroid glands, or any injury, or it will recurrent laryngeal nerves. Now, treatment is economic, but the disadvantages are it is not suitable for the young patients. It may cause hypothyroidism, long latent period of response, contradicted during the pregnancies. Now, beta androgen blockers. So, beta androgen blockers, they improve the symptoms of thyrotoxicosis, and which due to the sympathetic overactivity. So it will inhibit peripheral conversion of T4 to T3, and the drug belongs to propranolol. So improve the symptoms of thoracotoxicosis, that is the palpitations, tremors, nervousness, sweating. So propranolol is has an inhibitory effect on the peripheral conversion, as I have already told you that it will inhibit the peripheral conversion of T4 to T3. So propranolol is mostly used beta blockers for this purpose. As a side effect of some drugs, there is a anti-thyroid effect, which is not given for a prolonged duration, that is lithium, amyloid, sulfonamides, phenytonin, and rifampicin. Now, there is another term known as the thyrotoxic crisis, which is known as thyroid strom. So, thyroid strom, as the name suggests, it is the severe hypothyroidism. So, it is more mainly due to hyperpyrexia, arrhythmias, nausea, vomiting, diarrhea, mental confusion. So it may also cause trauma, surgery, diabetic ketoacidosis, and myocardial infarction, etc. So the treatment is, first of all, hospitalization. Now another is propylthiouracil, now iodides, which is taken orally or from solutions, propranolol, IV corticosterone, which will not allow to convert T4 into T3. That's all for today. I hope you like my video. If you like, please like, comment, and share. And don't forget to subscribe. Thank you.